Today we are going to discuss a transport case of a late preterm child of 35 weeks. Shall we begin, ma'am? Yeah. So the history is like the child was a late preterm of 35 weeks plus 1 day with the history of transportation for Alexis history of subglottic mass.
Okay. How will you differentiate between term, preterm, and not?
So, term baby means 35 weeks and above will be term baby, whereas preterm will be less than 35 weeks will be preterm. That preterm can be divided into early preterm, late preterm. That can be divided again. Late preterm is a baby greater than 35 weeks, whereas moderate preterm can be 32 to 35, and the early preterm in some books can be 28 less than 28 weeks. And here went ahead with for the transport of the baby, and we reached the hospital on
So before going to the hospital, what all things did you arrange?
so as it we are gonna transport
So
that
we got information that it is a neonate.
neonate. So neonate, no, so we'll have to have some equipments with us for the transport of the baby. That is, we'll be needing an intubation set which include the blade, straight blade, and the ET2.
What is a straight blade known as?
Millets. And the ET2. ET2 size for the neonate will be calculated by the formula of age by 4 plus 4. And then we'll be
This child is anyway a preterm
preterm
child. So how will you take the tube?
Tube size can be with the finger.
Little finger.
Little finger.
Mostly we consider 3 as the size.
3 as the size.
If it is a preterm child, 2.5
will be. We can use. Then for else we also will be needing a transport incubator and also a radiant warmer. Then we'll be needing an O2 support, and also we'll be also needing other things like suction, NG tube, and other than that we can also use blankets and um, drugs, essential drugs if needed.
So, and make sure you remember wet flags. What is wet flag?
Wet flags is the mnemonic which is used for identifying the whether the child, the baby is having any.
Wet flag is basically what all things required we calculate based on the child. So W for
weight
of the child, E for energy. So if at all the child goes into cardiac arrest or in case of arrhythmias, energy is E. Okay. So energy, what will be the energy we will be selecting if the child goes into cardiac arrest?
We can select up like 20.
Joule energy is calculated based on the weight of the child. So if the child is in cardiac arrest, we can select the energy as 4 joule per kg. So if the child is only 2 kg, then 4 joule per kg means around 8 joules only we will be able to give. And we can increase up to maximum 10 joule per kg. So if it is 2 kg child, you can increase up to 20. Okay. What about in case of arrhythmias, tachyarrhythmias? What will be the joule per kg?
That for will increase it up.
You can start from 2 joule per kg. You can increase to 4, then 10. Okay. That is the energy for cardiac arrest and arrhythmias. Then T. T is for
Tube size.
Tube size that we have already discussed. Then F. F is for fluids. IV fluids. So mostly in children we will be using either half DNS or any whatever solution we are taking for the child. We will be isolate B or whatever it is. We will be taking the fluids. L. Lorazepam. If at all the child is, if it is not neonate, we are not anticipating any seizure. But if it is a pediatric child, lorazepam per kg dose. So what is the dose of lorazepam in case of seizure?
And lorazepam can be given a dose of 2
per kg dose.
Point 0.2.
0.01 to 0.05 mg per kg lorazepam is the dose. Then flag, so F is over, L is over. Next is A. A is adrenaline. So what is the dose of adrenaline?
0.01 mg per kg.
0.01 mg per kg. In that is what concentration?
1 in 1000.
1 in 1000. What about in ml?
0.1 ml.
0.1 ml per kg. 1 is to 10,000. Okay. And G is for glucose. If at all the child is going for hypoglycemia, especially neonates, they are prone for hypothermia and hypoglycemia. So that is glucose. So how much should we take glucose?
Glucose 10% dextrose is given for neonates. And
what is the dose? 5 to 10 ml per kg. That is the dose for this. So wet flags, everything should be arranged. Along with that, the tubings, the equipments, monitoring equipments, adequate light source should be there. That also should be. Even the tube we are selecting, the blade we are selecting, adequate light source should be checked. All the drugs, IV cannulas, fluids, and resuscitative equipment should be arranged. That is one thing. Then, and we are going to the hospital. Okay.
So here on reaching the hospital itself, on arriving, we went to the ICU, and there itself the child was having a stridor episode, and child was having an abnormal breathing. Coming to the past triangle itself, from the assessment from there itself, in the appearance, the child was irritable, crying, and no, it was not consolable. And for then the work of breathing, the child was using accessory muscles for respirations. Nasal flaring was there, subcostal retractions were there, and also the child coming to the circulation, the child was having cyanosis. Means the child's limbs were little bluish in color, but the body was pink in color. And the child was given a nebulization of adrenaline.
So you finished PAT triangle, no? Primary survey?
Primary survey, the child is so the child was having a respiratory. So in the primary survey, appearance wise already according to PAT triangle.
How was the airway?
Airway was, the child was crying, but a stridor was present.
Okay.
And there is the history is like the child was having intermittent stridor. So the child was given nebulization of adrenaline there.
So how will you take adrenaline nebulization?
Adrenaline nebulization 0.1 mg can be diluted in 3 ml of saline, and can be given.
You can. There are two adrenaline doses which you need to remember. One is adrenaline nebulization. That you can take 1 ml. That is 1 mg in 3 ml NS. You can take and you can give it as a nebulization. And another one for crew. In case of this is neonate, we are not expecting a crew. What is the dose in crew? What epinephrine nebulization? What is the percentage? 2.25% racemic epinephrine. How will you give that?
That's given in mixed with normal saline and.
How much racemic epinephrine is being taken?
0.1 mg per kg.
You can take 0.25 to 0.5 ml. That can be mixed with 3 ml NS and can be given. Or if you don't have racemic epinephrine, you can directly take 3 ml of normal epinephrine with 3 ml NS. That is racemic. That is to compare with the racemic epinephrine. So 3 ml adrenaline means 3 mg. 3 mg plus 3 ml NS. That is the racemic epinephrine dose given for crew. Whereas if you are planning to give only adrenaline nebulization, you can dilute 1 ml in 3 ml NS.
So here nebulization of adrenaline was given in the airway part itself.
So you are feeling that it's a stridor. So was there inspiratory stridor or expiratory stridor?
It was more like an inspiratory stridor.
Inspiratory. So when will you expect the inspiratory stridor?
Upper airway obstruction.
Anything above the glottis. So supraglottic we are expecting inspiratory stridor. Whereas subglottic area, what will you expect?
Subglottic area will have in expiratory stridor.
Both. There can be expiratory and inspiratory stridor. Okay. Okay, then you have given nebulization with epinephrine. What
And
happened?
coming further, we went ahead with the primary survey. In the breathing part, in the breathing part, the child was having a respiratory rate of over 100
Okay.
respiratory rate, and saturation was initial saturation was in the 80 region, which jumped up following the adrenaline nebulization about to 1995.
Okay.
And in the circulation, the child was having a heart rate of 160 to 180 per minute with the uh, peripheral pulses, means child was having a brachial pulse.
When will you tell a neonate is in tachycardia?
Neonate will be his heart rate will be normal heart rate will be from one for more, mostly it will be up to 180. If the heart rate is greater than 200, we can
220. If it is neonate, more than 220 is considered as tachycardia. Okay.
And then coming to the disability wise, the child was crying, and
Okay.
nebulization was
GCS?
GCS. The eyes was closed, so it was not. Patient was not opening. Child was not opening the eyes. In verbally, the child was crying.
So, what is the difference between adult GCS score and child's GCS score? What is the main difference? Eye opening and movements will be same. Only verbal response will be different. What is the difference in verbal response?
Verbal response, the child won't be talking, so child will be crying, or either some sounds will be produced.
No, did you understand what I meant? Eye opening will be same in case of adult. So if the child is spontaneously able to close and open eyes, that is considered as E4, and like that of adult only. Movement also towards child won't be able to obey us, but still rest of the movement to pay, rest of the things are same only. Verbal response is the difference because that is slightly different from adult and child. So we are calculating V5 means the child is actively cooing, making sounds and all. Okay. As this decrease and as this decreases to verbal response to pain, these things and all, the point differs. Okay. So verbal response between adult and child is different. Okay. So this child
was crying.
Crying. Okay.
Then in exposure wise, we were able to see intercostal and subcostal retractions, and child was moving his lips. Coming to temperature was the staff in the ICU was looking at the temperature, and temperature was within normal limits, and was under a radiant warmer. The child was under radiant warmer. So after the nebulization, we waited for the nebulization to end, and following the nebulization, his breathing difficulty decreased, and stridor also reduced. The child cry was stopped, and the child was having the respiratory rate was coming down. Respiratory rate came down less than 60, and the heart rate was in 160 region, and the chest subcostal retraction and also reduced. And we then prepared for transfer of the child.
Okay. Now what all things to be transferred? Now we have already told what all things you have arranged, and we have reached near the baby. Now what is the next step?
So next step will be, as the child was in a nasal NAV support with the pressures of PEEP 6 and the pressure support with the pressure support also. So for transporting this child, we'll have to have a NAV support for transferring the child.
If the child is in 2 liter oxygen, that means already child is on PEEP support. That is considered as CPAP for the child. Okay.
So here the child was in NAV support with the PEEP of 6. So we had the NAV ventilator with us. So with the help of nasal cannula, we transferred the child to our radiant warmer incubator, transport incubator with the NAV support with PEEP of 6 and pressures.
So the second step in transportation is just before transportation. That means stabilization of the baby. So we have arranged everything. We have reached the child. We need to assess before shifting or before accepting the case we need to assess the child and we need to make sure the child is stabilized. So here you have told that adrenaline the nebulization was given, then child is being stabilized. So critical step, it is a critical step. So child should be stabilized, then only we should accept. Okay. If at all the child requires intubation, that should be done, because in the ambulance it will be difficult to do. So that is the second step. Then the third step is in the ambulance, make sure that the child is not going to hypothermia, because the child is neonates are highly prone for hypoglycemia and hypothermia, so that should be prevented. So as you told correctly, you have shift the child into the warmer. Okay.
So the child was also covered with the warm blanket.
Okay.
And we shifted the child from the NICU to our transport vehicle, and we connected the child to the monitor. And before even starting with the travel, we again check with the vitals of the child to check whether if at all any derailment in the vitals are there. His heart rate was above 150 with the respiratory rate less than 50, 50 to 60 was the respiratory rate, and child's cry reduced.
So before starting the vehicle, make sure that you are anticipating complications on the way. So on the way, inform the hospital itself that we might come back if the child worsens on the way, or we'll have to inform the we'll have to be prepared before reaching the destination. The child might be sick. So in case we will have to drop in another hospital, we need to be prepared for that. So we have to take the contact numbers of the other hospitals also in our hand. Along with that, we need to inform our team to be ready. Okay.
And we have also got a consent from the child's parents regarding the same, and consent was taken, and we started our journey. Along the journey, there was no other complication, and the child was transferred to our NICU facility without any complications. Upon reaching our NICU, vitals were checked, and the child was transferred into HFNC. And further evaluation for the cause for the stridor was done.
So what will be the differential diagnosis of stridor in a child, in a newborn?
So the history of the same. Shall we just on history is that the child was a 35-week respiratory distress, and the child was intubated, and surfactant was given, and following the surfactant, the child was extubated, and on third day the child had stridor, and further evaluation was
After extubating.
extubation. After extubation only the child developed stridor, and they were suspecting, outside hospital was suspecting a subglottic mass.
Okay.
And for the subglottic mass, they referred the child to our hospital.
Okay. Other differential diagnosis?
Epiglottitis, foreign body aspiration.
Epiglottitis, then?
Laryngeal bronchitis group such as.
All these are expected in a child more than 6 months. Croup, bacterial tracheitis, laryngeotracheobronchitis, any retropharyngeal abscess, or foreign body aspiration, everything will happen in a child more than 6 months. In early 6 months, laryngeotracheomalacia can happen. That is common in a child while crying, or when the child is very irritable, that can happen. And if the child is kept in a supine position, the epiglottis is very lax, and it is like somewhat in omega shape, and also it will fall, and the child, there will be airway obstruction. That will relieve with prone position and all. Mostly the management is conservative in laryngeotracheomalacia. Then other DD?
Other DD, the child had a history of intubation. The post-intubation traumatic stridor can occur.
That is mostly because of the subglottic stenosis.
Subglottic stenosis.
Okay.
Then vocal cord palsy can occur. Then
so which vocal cord palsy will cause stridor?
Abductor palsy will cause the vocal cord will come close together and can cause stridor.
Usually bilateral vocal cord palsy. If the child is born with bilateral vocal cord palsy, only stridor will be there. If only one side vocal cord is there, only hoarseness of voice will be there. That itself won't be identified, because that is the child's new sound. So nobody will be able to identify that. Then another causes?
Then we can have some history of burns.
Burns unlikely. Congenital causes can be there. Either any vascular rings or slings, especially children with any cardiac abnormalities. This might be there. If at all, we are able to do a flexible angioscopy and we are identifying it as a sling or a ring, something like that, this child will require an echo and a cardiological evaluation. Okay, and that requires to be treated. And another differential diagnosis is hematomas. If there is any hematoma, usually it will subside within 5 years. If it's not subsiding, any laser therapy or anything should be done for the child. Okay. So this child mostly might be a subglottic stenosis secondary to intubation, or they were suspecting in terms of mass also.
So here for further finding out the cause for the stridor, we went ahead with the ENT consultation was given and the laryngoscopy was done. So laryngoscopy revealed the both vocal cords were close together and thereby a bilateral abducted palsy was suspected. So we again did a CT of the neck. MTCT neck was done, which was not showing any obvious subglottic mass as such. And further, so the child was started on injection dexamethasone with the nebulization of adrenaline, and again a re-endoscopy was done. And during the endoscopy, it was found that the child has having a right vocal cord polypoidal mass, which was causing the stridor.
Okay. And what was done for that?
Dexamethasone as such was initially started, which will indeed help in reducing the stridor and
any removal or anything?
Removal was not planned.
Okay. So suppose this child asked on the way, what algorithm will you follow?
Neonatal resuscitation.
This child was born 5 days back, right? Day 5. So when will you do neonatal resuscitation?
Initial after birth of the child.
After birth. So till when? Neonatal resuscitation is only done if it is within 24 hours of birth. So this child is day 5. So whenever the child asks on the way, since it is more than 24 hours, we need to go ahead with PALS, pediatric cardiac arrest management. Okay, so suppose you are working in a labor room or you are working in an ER and you are seeing that a pregnant lady delivered a baby. So gynec team is taking care of the pregnant lady and the child is in front of you. So how will you go ahead with that patient?
So here we'll follow with the neonatal resuscitation protocol. So here we have to know whether that initially we'll have to have a before even the delivery we'll have to counsel parents and we'll be ready for the same. And we'll have
antenatal
counseling and team briefing is needed.
And equipment
check also needed.
So before the birth, antenatal counseling, team debriefing and equipment check should be done. Okay.
And post the main things we have to look is whether the baby is a tame baby and post delivery good tone is there or the baby is crying. If at all the all 3 points are met, then the child is good that we can keep the child in dry, stimulate the child and keep the baby in mother side. If any of the above is not met, that is if the baby is not having a good tone of the baby is not crying or if, then we'll have to follow the neonatal resuscitation protocol. That is, we'll have to suction the baby, position the baby, dry, stimulate the baby. And
that is only done in a term baby.
Term baby.
What about a preterm baby? Preterm baby, we are not supposed to warm, stimulate and all. Preterm baby should be covered in a plastic wrap and should be transported immediately with oxygen. Only in term babies we are supposed to warm and all. Warm, dry and all.
So following drying, stimulating the baby, if the baby is having a heart rate above 100, that's okay. We'll further keep the baby with the mother and if, we'll check for the heart rate, and if the child is having a gasping apnea or the heart rate is less than 100, we will again we will reposition the airway, suction and try to stimulate the child.
How will you position the airway?
We will
because the child's head will be very big as compared to the body. So whenever the child's head is there, there is a high tendency that the head will be placed on the bed or on the floor. That head will be in a flexed position, so the airway will not be patent. So head should be extended. For that, we will have to keep a thin pillow or a cloth under the shoulder blades. Then only the head will be extended.
And we will again stimulate the baby, look whether the child, there is increase in heart rate. If there is no increase in heart rate, we'll give the child a positive pressure ventilation, and we'll look for the heart rate. If the heart rate is
What breath is that called as? How much will you give? How much breaths will you give?
just to have a chest rise.
You are supposed to, in that scenario, so initially you have done the dried, warm, done all these things. You have given a suction, you have positioned the airway. You are still feeling the child's heart rate is less than 100. Then we are starting with the resuscitation. So the first step is to not ventilation. It is called as inflation breaths. That means the child is just born now. The child's lungs has to expand. So for that we will have to give inflation breaths. So inflation breath is usually in a cardiac arrest. How will you give breath? Each breath over how many seconds?
Or 1 second.
Over 1 second. This breath is different. This is each breath should be given over 3 seconds. Because our aim is not to ventilate the lung, our aim is to open the lungs because our lungs have been opened so far. Okay, so we will have to keep a pressure peak of 5 and we will have to give 5 inflation breaths. So each breath over 3 seconds. So it will take around 15 seconds. Then we will reassess again. What will you reassess again?
Again, we will check for whether heart rate is greater than 60 or not.
Heart rate, we are expecting a heart rate more than 100. Less than 60 means it's cardiac arrest. So more than 100, then we need adequate chest expansion and the tone of the child will assess. If that is not there,
then we'll continue with the positive pressure ventilation.
That should be done. So we are going to the next step. That should be done with 2% technique. Same 5 breaths over 3 seconds will be given with 2% technique. This can be given with 1% technique. Then you repeat the same with 2%. So one person will be holding the mask with easy technique and the other person will be giving the breaths. Okay. Then if that also thing.
Then we'll have to go with definitive ventilation, intubation, and we'll give alternative.
Now, next step is ventilation. We have only inflated the lungs and we have only opened the lungs. Next is ventilation. We will have to ventilate the lungs. So for ventilation, we will have to give ventilation breath. So ventilation breath, how will you give? Over 1 second. You will have to give 30 ventilation breath over 1 second. So 30 breaths each means 30 seconds. So wait for 30 seconds, give those 30 breaths. And if the child is still not responding, then you will have to start not intubation. We don't have time for intubation. Next step is CPR. If even after giving 5 initial inflation breath, second with 2% technique, again inflation, again we are giving ventilation breath. Even after that the child is not responding, next step is CPR. Okay. So how will you give CPR? What is the
CPR can be given with 2 finger technique, either with the 2 thumb or 2 finger, index finger and middle finger. We can either keep the baby with the both hands and give compression like, or else we can use the both finger and give compression.
What is the compression ventilation ratio in unit?
That is if at all 15 compression 2 breaths.
That is in case of pediatric cardiac arrest. In neonatal cardiac arrest is 3:1. 3 compression followed by 1 ventilation. Okay. And we will have to do that for 30 seconds. And even after that, if the child is not responding, then the next step is epinephrine. Okay. Then only the role of epinephrine will be coming. Okay. That is how you go ahead with neonatal resuscitation. Okay. Anyway, luckily for this child that was not required, and this child was diagnosed to have a polyp. Okay. How is the child now?
Following the steroid usage and the adrenaline nebulization, the child's tidal stopped. Actually, the child is breathing without any O2 support, maintaining in room air, and is discharged.